Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. We have a live episode this week, Friday from 11 to 12 Eastern Time. We're going to talk about funding telehealth's future with a great panel and your questions. Marie Savekis, Chime Public Policy, is going to really spearhead the conversation. We have Praveen Chopra, CIO for George Washington University, Dr. Stephanie Lahr, CIO, CMIO for Monument Health, and Albert Oriol, the CIO for Rady Children's in San Diego, as rounding out the panel. I'm really looking forward to this. I think it's going to be a phenomenal conversation. If you're wondering what the future of telehealth funding is going to be, you're going to want to tune into this and interact with our panel. Mark it on your calendar, invite a friend. Let's make it a party this Friday, 11 to 12. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that's how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. This morning, we're joined by Charlie Larsen, the RN Senior Director at Banner Health in Phoenix, Arizona, where he oversees Banner's Access Center operations. In addition, he is currently serving in a temporary role as RN Program Director for the Arizona Department of Health Services COVID-19 Emergency Response Team. And Angie Franks, the President and CEO of Central Logic, an industry innovator in enterprise visibility and tools to accelerate access to care. Wow, those are big introductions. Good morning, you guys. Welcome to the show.
Great. Thanks for having us.
Good morning. Thank you.
Yeah, I'm looking forward to the conversation. You guys have been busy, and I think it's for good reason. I think it's a really interesting solution. So Arizona Surge Line is what we're going to be talking about, and it provides transparency across the state of Arizona for constrained resources during the pandemic. I'm just going to throw the questions out. You guys determine who's best able to answer it, but I'm just going to start with the beginning. So what's the genesis of the solution?
Well, I'll go ahead and start, and then Charlie, go ahead if you want to jump in. The genesis overall for Central Logic of our solution, we have been in business for over 10 years working with health systems on helping orchestrate care, getting patients to the right location for the care that they need in the most timely and efficient manner possible. And typically, these have been patients in high acute with high acute conditions. So that is all about making sure that that they get that care and generate much better clinical outcomes. Banner Health has been a client of ours for a number of years, going on 2 years now, and have been doing some really innovative work with Central Logic. And I would say that was the genesis of how we got started with this project in the state of Arizona. And Charlie is certainly the right person to describe what that's all about. So Charlie, I'll let you give an overview.
Oh, sure. Thank you. So as Angie mentioned, Banner Health has been a client of Central Logic now for going on 2 years, and have had a lot of success with it. And as this COVID pandemic has started to spread, or has been spreading, the Department of Health Services here in Arizona reached out to some of those states that were hit earlier, and reached out and just try to find out what do they wish they had done differently, what's gone well. Because in Arizona, we've been a little bit lagging, not lagging, but we weren't experiencing the surge at the same time as some of these other places were. So we were much more in preparation mode. So one of the things that we heard was, you never know where these pockets of COVID-19 outbreaks are going to pop up. And depending on where they are, the hospitals in that area, being the closest hospitals, can get overwhelmed very quickly, as they saw in New York. And so what they told us was, we'd have some hospitals who are, bursting at the seams and need ventilators, need capacity, need nurses, and we have other hospitals with capacity and everything kind of waiting for patients. And so what they had wished that they had done is exactly what we enacted, was something to load balance these patients as they're being transferred around the state. We work to get them across the different organizations, across the different hospitals, so that no one hospital gets overwhelmed, while again another one has the resources available so that they can get the quick access to care. So in partnering with Central Logic, we've been able to do that successfully with all the visibility and the integrations and protocols and procedures to make that successful very quickly.
Wow. All right. So I'm going to go straight to the questions I think a CIO for a health system would ask. Obviously, Banner, I think it's the largest in Arizona, but you have Dignity, which is now Common Spirit. You have, you have so many great health systems down there, but you have a lot of small players as well. You have Honor Health and some others. So you're going to have to integrate all those in order for them to communicate at a state level. What does that look like? How do you stand that up?
Yeah, that's right. So there are quite a few kind of what we would, as they use bunny ears here, major health systems in the Phoenix metro and Tucson metro areas. And what we found that we needed to be able to see and integrate and work together on the most was the bed visibility. We need to know who has beds, when, and where. And with that, we need to know who has ventilators and who has the staff and those kinds of things. And so a big win for us was that and what made this successful earlier was that our state health information exchange, Health Current, already had ADT interfaces with 95% of the state. And so where with Banner Health, we have a specific integration with Central Logic for our own bed visibility. What the HIE allowed us to do was to have Central Logic interface with HIE to get the information and translate it into the language that we needed to be able to see the beds. So it was a very quick turn on, I guess, to be able to see the beds across the state. And it's not really a flip of a switch for everybody at once. So we start with the bigger systems and then just keep kind of plugging away until we get everybody's bed visibility.
So is it basically just ADT feeds? Is that what you're picking up from the EHR and from the HIE?
That's really the basis of it, because the ADT feeds, they has the information in there that has, all of the beds mapped. And so where are the beds located? What kind of service is it? Is it an ICU bed? Is it not? And then is there a patient in it? So with the ADT feeds, then Central Logic and Health Current has partnered to work together with each system, transfer center, each system, subject matter experts to, on the back end map. So if it's, the fourth floor in room 412, what is that bed? That bed is an ICU bed. And so we Central Logic has mapped all of those beds across the state with the systems, and then the ADT feeds will just tell us if there's a patient in that bed or not. That's really the basis of it. And then we get into, the ventilators and the reporting of those and those kinds of things, which will really round out our visibility across everything.
Yeah, so Angie, the natural next question is, if the HIE has a lot of this information, what is Central Logic's role at that point? Besides being an aggregator for the rest of it, I assume there's some reporting, there's some visibility, some dashboards and whatnot that you guys provide out of the box.
Right. Yeah, so the HIE made it easier, obviously, to have all of that data pulled together in one spot. But the technology that we've built and designed is really what what I would say is a key part of the secret sauce. It allows the health system, or in this case, the state and the call center at the state level, to have a master bed board and to have the visibility to all of those critical care beds and staff, the resources, the physicians, and then the ventilators, so that when the calls come in, the decisions that need to get made as to where's the best place for this patient to go, that agent has visibility to who has capacity, who doesn't, who's moving into a state where they've got maybe pending demand that is going to put them into a status where we don't want to route more patients to this facility. We want to leverage other resources in the state to move those patients. And if you look at places like, in Banner's case and in the state of Arizona's case, they had some time to prepare for this. They saw what was happening in other parts of the country. It may be that the folks in New York City and the state of New York did not have that time to prepare. But if you look at some of the things that happened, I know there was a story a week ago in the New York Times about, you have these health systems in New York City, and 15 minutes away, there's 3,000 beds across multiple other health systems being unused because they lacked the ability to understand and know at a coordinated state or regional level who had capacity and who didn't, and make those decisions in a centralized fashion. That's what we're bringing to the table. So we bring the tools and the technology to facilitate that decision making. The HIE provided us a much easier and faster way to get access to that data. Without an HIE, we would just pull that ADT data from each individual system.
Right. You can do it. It's just a work that's going to be done at each IT department. There's going to be a significant amount of work done in public health following this pandemic whenever it does run its course. And, it's these kinds of solutions. So from a public health standpoint, it really had to be driven by the state of Arizona. And I can imagine they have a dashboard at that level, but how does the provider sort of interact with that data? Do they go to the state and say, hey, where's their capacity? Or do they have visibility down at the health system or even at the hospital level of how to direct patients in the case of a surge?
Yeah, so the way that we've built the surge line is, it's the technology, of course, and like we've talked about with the bed visibility and then the reporting and everything that comes with that. But what it also is it's a center of agents that take these phone calls. So we have all these tools at our fingertips at the surge line. The referring hospitals, maybe in rural Arizona, they don't look at the bed visibility, the ventilator visibility. They pick up the phone and they call the toll-free phone number. And essentially with that call, they're calling every health system in the state. And so they're calling the surge line. The surge line will then, we have an algorithm of different things that we look at. We look at the critical nature of the patient, who has the related bed, market share, and who's got the most beds in the state. We want to make sure that, if one health system has 10% of the total beds and another health system has 50% of the total beds, we don't just want to divvy them up one for one. We want to make sure that we're following that. So we look at that. We look at what our last few transfers, where have they gone, so that we don't inadvertently send, 5 or 6 patients to one system back to back, so that they have the time to bed and kind of catch their breath a little bit before we come again. So they look at all these things. And this transfer center, the surge line, kind of sits on top of the other surge line, the other transfer centers. So we don't want to impede on their process flow. So we just, at the Arizona state level, we decide which health system it's going to. We hand the case off to that transfer center, and then they connect the physicians and follow their normal processes to get the patient placed. Does that make sense?
Yeah, that makes sense. I'm sitting here thinking, okay, if I were in charge of this in New York City or Pennsylvania or wherever, and we brought a task force together, and they said, all right, here's what we're going to do. I already sort of said, how the conversation is going to go. I can see people going, well, we have HIEs across the state. We'll just pull that information in and make it look nice. Then I can see people saying, well, most of our health systems are on Epic, so, can't Epic just provide? I mean, I would imagine the conversation in Arizona probably went down that path as well. It's like, we could do this, we could do this, we could do this. But the reason you can't, I would assume the reason you can't do that is because of it's not Epic across the entire state. Everything is not as integrated into an HIE as we would like. So it does require some sort of intermediary layer to aggregate and to function. Is that am I accurate in that assessment of how the conversation went?
Yeah, I'll let Angie talk a little bit about the interoperability of the platform, but what it does is this platform, and why it's necessary is it provides a whole charting documentation platform for our surge line agents, and so they will document the demographics of the patient, where they're coming from, are they COVID presumed or are they COVID positive, all those types of things, and with that. We pull all sorts of reports, all sorts of epidemiologic reports that will help us understand. Navajo Nation right now is one of the highest rates of coronavirus per capita in the United States, right there with New York and New Jersey. And so we're getting a lot of patients from northeastern Arizona, from Navajo Nation. And so that helps us understand how many patients are coming from that area at any given time. What are the trends? And we can look back since the surge line was stood up, and we can look at all those details that the transfer center charts. that is agnostic of what health system EHR is being used at the local level.
Yeah, and I'll just I'll just chime in, Bill. You are spot on that. The interoperability is the key here, and it doesn't even matter if you're on the same EMR. Many times across, even within a health system, but certainly across a state, even if you're running the same EMR, the same, you're all running Epic. You're on different versions of Epic. You have different configurations of Epic, and it does not. That those systems do not interoperate well. Our technology is truly Switzerland. We integrate not only with the EMRs and the ADT systems, but we integrate and interoperate with many other systems to facilitate the decision-making process and navigation process of getting patients to the right care. So I think you also have to look at something that is very purpose-built for taking in information, rapidly gathering the right clinical data, following protocols, time stamping and documenting, and then facilitating the decision, and then getting the transportation, ordering the logistics, and getting the patient to where they need to be. And it's just vastly different from what an EMR was designed to do.
All right, so this is what Arizona's doing. Any word on what other states are doing at this point? I'm throwing you a curveball. I don't really know. I haven't heard of anything like this yet.
Well,
I have heard rumblings of New Mexico doing something similar, but I haven't heard of anything, to this extent.
Yeah. So what I've heard and what I've seen is states right now. I think there's a conference call with governors and state task forces that are happening on a weekly or a biweekly basis. They're all looking at or attempting to do, or thinking about, how they're going to put in place the infrastructure to handle surge and demand in the future. But I haven't seen anything to the extent of what the state of Arizona has done. We have heard that the state of Nebraska tapped one of the CHI systems, and it's another Central Logic client, where they are facilitating a similar type of a surge demand, kind of a centralized function, but it is being routed through that health system for decision making, is my understanding. But we have not seen any other states go quite to the level and the vision that Arizona has implemented against.
It's interesting. I mean, we need data to make decisions, and I see all across the board. You guys are talking on a state level, but even on a national level. And I see even the military is moving those ships around. They're moving them to New York Harbor, then they moved them into on the West Coast, where, there's so many people that could use. This pandemic may not have hit the surge numbers that people anticipated early on, so those ships were not used and the field hospitals weren't. But to have that even on a national level, you realize there's so many pieces being moved around based on data that's being cobbled together or is not complete. This would be an interesting, one of the first public health programs that should be put in place almost nationally so that we can make decisions in future pandemics.
I think it is absolutely essential that there is a technical infrastructure to support this type of logistics and this, patient navigation and logistics in the case of any surge. And that could be a mass shooting, it could be a hurricane, it could be an earthquake, the next pandemic, a bad flu outbreak. It is really, in my opinion, fundamental to good public health that we have the ability to integrate, communicate, orchestrate care, and turn that on a dime when the conditions demand it.
Absolutely. Well, I want to thank you guys for the work you're doing in Arizona. I love your governor. I love following your governor. I follow him on LinkedIn and see some of the posts. Some great work being done down there in Arizona, and the work you guys are doing is excellent. I'm glad we're able to share that with the community, with our community, and get that word out there. So thanks for everything you guys are doing.
Thanks for having us on, Bill. Good to talk with you today.
Yeah, thanks for the time.
Appreciate it. That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, most of you can say this now without me even finishing it. The best way to do that is to share it with a peer. Stop right now, send an email, tell somebody, hey, this is a great show. I'm getting a lot out of it. You're going to want to check out these interviews and conversations. The second best way you can do it is you can subscribe to our YouTube channel. We're putting an awful lot of new stuff out there, and it's exciting. The live show will only be available on the YouTube channel. It will not be dropped into the podcast channel. Some of you asked me to drop it in last time, but my team here internally wants me to stay focused on the strategy, and that is to have content that is specific to YouTube and to start to diversify our channels, if you will. So some of our content will only be available on YouTube. So get over there and subscribe so you know when it's available. Please check back often, as we're going to continue to drop shows on a daily basis through the end of June or until we get through this pandemic together. Thanks for listening. That's all for now.